Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for 12/2/21, a new month. Since last conference, we've had Thanksgiving, a new COVID variant, and a nephrology match. Some of this is good and some of it's not so good, but the match went well. We congratulate everybody and we welcome everybody that may have matched or will match, and good luck to all the programs. We've got a great case today. It's a two-parter. Dr. Whittier is going to walk us through the two parts. We'll have two different discussions and show the pathology twice. Today's CME activity code is 484222. This conference is being recorded. The patients have been de-identified and we have nothing to disclose. So Bill, you want to walk us through part one of the case?
Yeah, thanks. Melanie, you want to start?
All right, so this is a case of a patient. She's a 57-year-old Black lady who presented 10 years ago. She was 47 at the time for evaluation of microscopic hematuria and proteinuria. Her UA was positive for +3 protein and +3 blood by dipstick. She had 38 microscopic RBCs. Her urine protein to creatinine ratio was about 6.1 grams per gram. And she also had new onset hyperlipidemia. At that time, her ANA was weakly positive, but her complements were normal and her double-stranded DNA antibody was undetectable. And then her other serological workup was also negative. Her past medical history is significant for asthma and hyperlipidemia. Past surgical history, she had an unspecified leg surgery back in 1976. Social history, she's no tobacco use, no drugs, no alcohol. Family history, her mother has a history of diabetes, breast cancer. Her father had had a stroke, and her sister has heart failure and breast cancer as well. Her review of systems is positive for leg swelling at the time, no skin rash, alopecia, arthralgias, no fevers, coughs, chills, or pain. She had no allergies. Her medication list at that time was atorvastatin 40 milligrams, cholecalciferol 2,000 units daily, Lasix 40 milligrams daily, and losartan 50 milligrams daily. On her physical exam, she had positive edema. Her renal ultrasound showed 2 normal-sized kidneys without any hydronephrosis. So she underwent a percutaneous kidney biopsy.
Great. Any questions? No, then let's see. Dr. Gash, do you want to tell us what your thoughts are?
Yes, this is a lady who presents with essentially nephrotic syndrome, but she also has hematuria, a good amount of it, 3+ blood with 38 RBCs, and also accompanied by hyperlipidemia, which is probably associated with the degree of her nephrosis. The ANA is weakly positive, so this makes me think that, an African-American woman who with a positive ANA in this clinical picture is presenting with lupus, and her presentation is lupus nephritis. Because of the degree of proteinuria, I'm going to think maybe membranous. But if the ANA is a sort of a non-specific positivity and she doesn't have lupus, because it doesn't sound like she has other clinical features of lupus, she could also have the limited types of nephrotic syndrome, which is, the triad of FSGS, minimal change, and membranous. Because of the degree of hematuria, the membranous and the FSGS seem more reasonable. Minimal change fits because of the hyperlipidemia, but there's a little too much blood for minimal change disease, so that's probably a little less likely. Other things, I know she's African-American, but IgA nephropathy could fit this with the hematuria and proteinuria. But I think I'm going to go back to my initial number one, which would have been a lupus lesion because of the ANA. Despite the fact that she's got normal complementemia and negative double-stranded DNA, I'm still going to go with a lupus feature, which I guess we should see the fluorescent and biopsy should confirm or negate that. So that's my order. I think I'm going to go with a lupus lesion that would be membranous plus minus other things possibly. And then after that, African-American, I would say FSGS number 2, number 3 membranous, number 4 minimal change, number 5 IgA.
And why do you have minimal change in there?
The hyperlipidemia, the degree of proteinuria, she has nephrotic syndrome with hyperlipidemia, so minimal change should be on there. I know there is a little bit of blood, but It's on the differential, but it's, number 5.
Yeah, that's fine. What was her creatinine? Did I miss that?
Normal.
It was normal. Okay. Anybody else have anything to offer our differential?
Only other thing I would add, and again, I wouldn't put it high, would just be in terms of her age, I guess 47, a little younger, but a paraproteinemia related lesion, less likely, but again, something we should consider with the hematuria, proteinuria. We have a UPC ratio. I don't think we have a UAC or anything like that, but that's something to consider on the differential. But outside of that, I do like the aspect of the ANA being positive, lupus, FSGS membranous.
Yeah, I mean, this is biopsy conference and we do biopsy a lot of lupus, obviously. And there's serologies can be quite variable in lupus, but then there's a lot of people that have a positive ANA and it doesn't mean anything. And with their complements being normal or double-stranded DNA undetectable, I don't know if I'd have to put that first. I might have to put membranous first, or focal sclerosis, to be honest. Although there's a fair amount of blood for either of those. I don't know. I just would be a little surprised you don't have. I mean, the complements don't bother me if they're normal. We see that double-stranded antibody undetectable. I don't know. Dr. Corbett, do you agree with me that where would you put first, Steve?
I was thinking latent lupus nephritis, if you wanted to be, kind of goes along with, I think, what Casey had said, with membranous lupus, they may not necessarily have any serologic or even clinical symptoms early on, and the biopsy is kind of how you make the diagnosis. So, I mean, I think that's, the ANA being weakly positive is kind of a little bit suggestive, but I think latent lupus is a good thought. Again, the 38 red cells, I mean, sounds, it seems like a lot, but you can have that in membranous lupus. You can have it in minimal change disease, usually not that much, but in adults up to 25% or so can have microscopic hematuria at presentation. Now, I don't know if some of these people were really misdiagnosed as having minimal change when they could have had FSGS, but I mean, that minimal change can have some microscopic hematuria. I mean, the suddenness of the onset and everything, I mean, the differential that Casey's so nicely gone through is really, I think, a good one. And I think, membranous lupus is not latent membranous lupus is not a bad thought. Now, I was sitting here trying to think what more is going on. I saw the sister had heart failure. I was trying to get a little more in the weeds on this, but no one else has a history of heart failure, and there's no history of polyneuropathy, I assume, because I was thinking some sort of familial form of amyloids, like transthyretin associated. But it's kind of hard pressed. I mean, there's really not enough that goes along with that. I was just trying to think of something kind of more strange. I mean, I guess we could go down the path of, immunotactoid or fibrillary GN to get into the more unusual things. But I think realistically, the differential that Casey threw out was a good one.
Yeah, I think about it, I think you're absolutely right. And I guess what got me off of that, I mean, if I just read this case without the blood, that's of course what I would say. African-American woman with proteinuria with a mild ANA, it does not hardly dissuades me from lupus. It's the complements in the DNA that I was talking about. But I think what got me off the track there was the blood. And that's not that unusual. So I think, yeah, I retract everything I said, and I agree with you guys. Let's spin the wheel.
Well, thank God the wheel still works.
Nothing electric in the wheel. It has to work. Wild card. Wild card. You know what? I'm going to have Dr. Gashti stick with this.
All right.
All right, Casey, give me a second.
Yeah, second years are very happy that this is December. They've got one more month of being on that wheel, and then the first years pop up there, right? In January?
That's right. That's right. Come January, they'll all be sick with the on Thursdays.
All right, Casey, go ahead and click. Yep, you're controlling the screen. Or I can advance the slides. I'll advance the slides.
Okay.
Let's see.
This is a trichrome stain, low power. I see from this power, there's quite a bit of blue staining material. This is kind of spread out through the middle of this core. I see glomeruli. They don't look completely normal, but I'm just going to save my comments for a higher power. The middle of the slide has an area where there is just more than usual tubular interstitial blue staining material. So I think if I take it all together, maybe about, I don't know, somewhere between 25 and 50% of this core looks like there's fibrosis set in, but the glomeruli look actually pretty amazingly preserved. So that's pretty much my comment on this one.
Yeah, there ended up being 15 gloms. None were globally sclerosed. There was a little fibrosis there in the middle, but actually in the entire biopsy that I couldn't photograph, it was just on the focal side, 15% or so. So
Okay.
it's not much chronicity.
Okay. Next slide. All right, so here's an H&E high power, the glomerulus right in the middle of the screen. At both 2 o'clock and 4 o'clock, I see a couple areas, and also 9 o'clock. There are areas of hypercellularity. I can't see the lumen of the capillaries. So what we used to call endocapillary proliferation, can call it hypercellularity at this point. There's also mesangial expansion. There's definitely more than 3 to 5 nuclei per high power field. So there's both hypercellularity and mesangial expansion that we see. I'm trying to see if I see any kind of a karyorectic debris. There's nothing that stands out to me right off the bat. We may see it later. There are some higher, sort of darker pink areas. Those may be unlicensed RBCs. So I'll, maybe different stains will give us some ideas, but there's some abnormalities in the glomerulus. And then if you look around, there's some tubules look okay. The artery that's right outside. I don't know if this is sort of fibrin that's on the wall, a little bit in the pinkish area, or is it just a normal stain? And then
Yeah, I didn't see any break or rupture there, so I think it's
Okay.
just a little funny
Okay.
staining.
And then there's a little blob of glom. I think there's a capillary tuft right on top of
Yeah.
this one, and that doesn't look normal either.
Yeah,
So
David?
hypercellular.
yeah.
Hey, David, so at like 4 o'clock, there's a lot of mesangial hypercellularity, but at 4 o'clock, it looks like there might be some karyorectic debris, or am I overreading that?
Yeah, so I agree with Casey. There are areas of endocapillary hypercellularity. There was another glomerulus that did have a small necrotizing lesion, but I think because of time constraints, it might not have made the presentation. But
I guess what I'm getting at is that, sometimes it's hard to tell, really severe mesangial hypercellularity from what we would call some kind of a segmental proliferative lesion, that's actually occluding the loops. And how do you finally make that distinction? Is it what Casey said, the lack of capillary loops being open?
right. I mean, take that segment over there at 9 o'clock. There's no open lumens there, and it's full of nuclei.
So that's more than mesangial hypercellularity, in other words.
Yeah.
Okay,
Yeah.
kind of that's kind of what I was getting at, because I see in the one at 4 o'clock, it's kind of the same thing, which I thought I saw maybe some karyorexis there, but because I think sometimes it's hard to tell what's just diffuse, expansion of the mesangium versus, endocapillary hypercellularity or proliferation, name du jour. So, all right, I'll shut up and we can move on.
Okay, we're jumping to fluorescent now, right?
Oh yeah.
This one,
okay.
here's the one.
Yeah,
You
yeah.
just got, yeah.
Gotcha. Okay. So this is another H&E, and this has a little bit more of a lobular appearance, closer to 4 or 5 o'clock. The epithelial cells that are sort of lining at the top of this tuft they're sort of they're a little proliferated. They look kind of like, I would, if it progressed, I would probably call it a crescent, but I don't think it's a crescent at this point. But they definitely look prominent in the Bowman space. You do have that area at 11 o'clock where there is endocapillary hypercellularity. There is definitely mesangial expansion and mesangial hypercellularity as well, but very abnormal. And this almost looks like diffusely proliferative lesion.
Yeah, the only thing I'd add at 12 o'clock there, I think there's a necrotizing lesion that's kind of transitioning maybe to scar. Because I do see some little bit residual kerectic debris, and there's a little light pink material over at like 2 o'clock, where you see that kind of,
Here.
that area. Yeah.
Got it. Okay.
Yeah,
Okay.
yeah. I think that's a necrotizing that's transitioning, starting to scar.
Okay.
Okay, then we saw that one already.
All right. Here's a fluorescent that's positive for IgG in the peripheral capillary loop, and it's in a granular pattern. You can see this huge areas of positivity in the capillary loop here. There is some mesangial deposits as well in these areas, but predominantly capillary loop. So as of this point, it is consistent with a membranous lesion.
Yeah, so the IgG is strongly positive. The M was only focal, and then the IgA was negative, so it didn't quite make it to full house.
What about C1q?
C1q was 1+.
Okay.
I'm a little surprised there's not more mesangial here. Are we going to see an EM?
Yes.
Okay.
All right, here's an EM. Sort of, let's see if here's a glomerular basement membrane. There is the capillary space or blood space. Out here is the urinary space. You can see huge electron dense deposits that are subepithelial, that are lining this area. It's sort of becomes mesangial right at the fold here, and then there are these huge deposits that go all the way around this capillary loop. Mesangial deposits are not as prominent. There are some in the folds, but these are the big ones that are subepithelial. The podocyte here is diffusely effaced. I would say I don't really see any normal slit diaphragm, or there's some villous transformation here. But so yeah, I think there's subepithelial electron dense deposits mainly. And some maybe mesangial deposits, but not as much.
Yeah, the mesangial ones were focal and small and pretty rare. I think we have one more image of a high power. Here we go.
All right, here's a higher power on that EM. Again, we're seeing these subepithelial electron dense deposits, blood space here, urinary space here, diffuse foot process effacement. Here there are some deposits here in the mesangial fold, but in this mesangial area, like we can't really see. I can see cell processes, but not, I guess these would be small electron dense deposits here.
Yeah, so we had 2 out of 15 glomeruli with those active lesions, and then as you described here, a membranous component. So I signed it out: focal proliferative lupus and membranous lupus.
So any subendothelial deposits or TRIs?
No, neither one.
All right.
David, I'm just looking there. That's not a TRI on the inside of that
Here?
capillary loop, but
Yeah, well, when I go up on higher power, it's an organelle in the cytoplasm.
So everybody's comfortable with this. The discussion was latent lupus, and everybody's comfortable with that diagnosis. Steve, you a little surprised about the segmental lesions?
I mean, what I'm more surprised about is there's not more mesangial deposits. That's the thing that I'm more surprised about. I mean, the proliferative and the necrotizing lesions, I mean, that goes along with lupus. I'm surprised. I'm surprised we're not seeing subendothelial deposits and more mesangial deposits. That's kind of what surprises me.
Well, actually, I was going to take it the other way because I'm surprised. My whole premise was with the serology was benign, and then you guys, brought up the good point of latent lupus, where with an isolated lupus membranous, you can see very minimal and sometimes no serology. So, I'm not surprised that there's the membranous if we're going to call this lupus, but again, to have some endocapillary proliferation or hypercellularity rather, and the immunofluorescence the way it is, with the normal complements and the double stranded. I'm still a little bit surprised. I don't deny the diagnosis. I have no problem with it. It gets back to what I was saying. I'm a little surprised.
This
Doesn't
is more like, I guess, the vasculitis that membranous can have sometimes, especially in African Americans, right? So the question would be, out of curiosity, whether an ANCA was ever positive. But as we know that these patients with membranous can have, this was much more of a diffuse, diffuse proliferative form of glomerulopathy. It seemed like, with segmental necrotizing lesions, we see that. I'm like I say, I'm surprised they're not subendothelial deposits, but we definitely saw that in the patients in the lupus study. The caveat is that you often had mesangial deposits and didn't necessarily have subendothelial deposits. So I still think it's consistent. I would be curious. ANCAs aren't generally positive, but they can be in some of these patients. So I'd be curious to see what the ANCA was.
Yeah, her ANCA was negative. And at this time, it was 2012 or 13 or something. We also obviously did not have PLA2R readily available.
Or exostocin, right?
Or exostocin, that's true.
But until there's a better diagnosis, I think this still goes along with membranous lupus until proven otherwise. And again, the complements not being low, I think, are a result of the fact that you don't see a lot of big, subendothelial deposits and the antibodies that cause the membranous are definitely usually don't activate. They'll activate complement, but not to the level of subendothelial, the antibodies that cause subendothelial lesions. And, again, if they have this kind of pauciimmune necrotizing glomerulonephritis, that doesn't necessarily associate itself with hypocomplementemia either. So, I think it could still fit. Somehow I have a feeling there's going to be a ringer here, but I'm satisfied with that diagnosis.
Well, let me ask Casey. Let me ask you this. Given, it's a really good discussion because clearly there's a little things that aren't typical. That doesn't change anything necessarily, but it seems a little atypical. What would you call this if we said the DNA, double-stranded DNA was negative, was normal, and the complement's normal? What if she didn't even have an ANA? Casey, how would you put this together with that pathology?
Well, there were some mesangial deposits. It wasn't a full house, but there were, in addition to IgG, there was C1q, and the IgA was also positive, or no?
IgA was negative.
Negative. Yeah, the mesangial deposits to me sort of make me lean. So there's a histologic description, and then there's the clinical diagnosis, right? So the histologic diagnosis here is there's a membranous glomerulonephritis, and then there's a necrotizing glomerulonephritis that's pauciimmune in nature. So those are the two things. But what does the patient clinically have? I think the mesangial deposits make me still lean towards lupus, despite all the other negative serologies. But I would check a hep C, make sure that's not a secondary cause and things like that. But I'm still sort of hanging my hat on this is membranous, whether it's primary or secondary. So I just rule out the secondary stuff. And if at the end you end up with nothing else, you could call it primary membranous. But I think the mesangial deposits to me are the deal breaker here. I'm still going to call this a secondary membranous.
Yeah, I think that's a really fair way to look at it. There is a literature on, seronegative lupus, completely seronegative, or lupus-like glomerulonephritis, with even full house when they have absolutely no serology and nothing else to suggest it. Those patients don't do well. And, but I think you're right. You think about infections and things like that, but we are left with what we have. Bill, why don't you take us to tell us, I won't ask what people treat. Tell us what you did, Bill.
Yeah, sure. Thanks. You want to go to the next slide? One more if you could. And Melanie, you can go ahead and give her course. Or I can, Melanie, if you're out. Oh, there you go.
Oh, no, I'm good. So she was diagnosed with class 3 and 5 lupus nephritis. She was treated with oral Cytoxan for 3 months and steroids and put on maintenance MMF. Her proteinuria resolved, but 1 year later, she flared with an AKI and nephrotic syndrome again. So Rituxan was added at that time to her MMF, and she again achieved remission. She unfortunately though flared again at 1 year, and Rituxan was given again, and then maintained at a 6-month interval for 2 years, and then she went like once a year until her current presentation. So 3 months prior to her current presentation, she developed a cough, dyspnea, and anosmia, and she was diagnosed with COVID, despite being vaccinated. She recovered with supportive care, and her annual Rituxan infusion was held. So her last dose of Rituxan at this point was 18 months ago. She now presents with diffuse anasarca, nephrotic syndrome again, and an AKI. Prograf and high-dose steroids, as well as Bactrim, were added until Rituxan could be approved for about 3 weeks. Her AKI progressed despite this therapy. Her medication list at this point was losartan, furosemide, rituximab, last infused again 18 months ago, MMF, Prograf, prednisone, and then Bactrim. Her physical exam at this point, she was hypertensive, and otherwise everything was normal except for like 3+ pitting edema of her lower extremities. So we're going through some of her labs. 8 weeks prior to this all happening, her creatinine was normal, her albumin was 3.9, and her UPC was 242 milligrams per gram. 3 weeks prior, her creatinine had increased at this point to 1.5. Her albumin is now 2.2, and her UPC ratio is now 10.4 grams per gram. 1 week prior, her creatinine again continued to trend up 1.9. On the day of biopsy, her CMP, her sodium, potassium were normal, as well as the chloride bicarb 21. Her creatinine on the day of biopsy was 2.23 milligrams per deciliter. Her albumin at this point is 1.5. I'm just kind of going through her lipid panel. Her LDL cholesterol is 162. Her white cell count was 21,000. We attributed that to her being on steroids. Her hemoglobin was 10.7. Her platelet count was around 200,000. Her UA had 4+ protein by dipstick +2 blood, 15 microscopic RBCs, and her UPC ratio is 12.4 grams per gram. Her C3 and C4 were normal, and ANA at this point was not done. Her double-stranded DNA, ANCA, rheumatoid factor, cryoglobulins were all negative. Her HIV and hepatitis B and C were negative. A PLA2R antibody was positive, and it was previously checked in the past and had been negative. A repeat renal ultrasound with Dopplers revealed that the right kidney was 10.2 centimeters in length, left kidney 10 centimeters. There were no focal renal lesions, no stones or perinephritic fluid collection seen. She had no hydronephrosis, and the main renal arteries and veins were patent. And so again, she had a biopsy done.
Can you go to the next slide, Pravir? So this is sort of just a summary, and maybe Pravir, you can handle the arrow. Of what, way back in the day in 2012, that's when she had her biopsy. We gave her Cytoxan steroids and it worked quite well. I had maintained her on MMF and did a steroid taper, just as Melanie said. It was, she achieved remission, and I thought it was going to be maintenance for lupus.
Bill, do you remember what dose? You remember what dose of MMF you had her on for maintenance?
I had her a gram twice a day, and then
Okay.
at 6 months we cut her down to 500 milligrams twice a day. She had been having some issues with nausea and GI intolerance. And then she flared, just like we said, and then that's when I decided to give her Rituxan. I actually did maintain her on Cellcept during that time. And then a year later, she flared again, and this time we gave her Rituxan, and we thought, okay, I'm never going to let her go without Rituxan again. We're going to get it every 6 months for a while. And then we kind of weaned it off to giving it every year. So it was given annually for the last 3 years. And then obviously COVID hit, and we decided or elected to hold it because she became diagnosed with COVID. And so and then now she's flared, and her last flare is, 18 months off of Rituxan. And this time it was a little bit different because we had AKI, and while I was waiting for Rituxan to get approved, I added high-dose prednisone, and we added Prograf. Despite that, her AKI was still persisting. So that's why we decided to do another biopsy. And the other thing that was different, of course, this time is now that we had a PLA2R that was positive at 280. Now, when I checked it before in 2020, it was negative, but that was also when she was in remission. I just randomly checked it once on her just to see if it would be positive, but she was also in remission. So her negative PLA2R a year ago may not mean that she's not primary. It might just be that she was in remission at the time.
Hey, Bill, had she gotten vaccinated?
She did. Yep. She was vaccinated and got infected despite vaccination.
Okay, so her infection was after vaccination?
Correct.
Okay.
And her presentation was 3 months after her infection.
Okay. I mean, obviously, we're seeing a lot of vaccination-induced relapses, and that's why I brought that up. But the timing is kind of funny. Casey, you want to tell us what your thoughts are now?
Yeah, so seems like she's having a flare. So it's a couple things here. One is this new finding of the positive PLA2R in the blood, which is interesting because if she is, that's a pretty high titer. I mean, it's a 275 is pretty high. I don't, it's not like right on the cusp. So I think that's real. And if that's the case, I mean, PLA2R is pretty close to, 95 to 100% specific for primary membranous. So if you believe that's true, then you have to call this primary membranous. So we'll see what the tissue shows. So does she have primary membranous and this is sort of a relapse, or does she have truly secondary membranous from lupus and the PLA2R is a red herring? I guess that's a discussion to be had. And if that's the case, her biopsy, I suspect that she would have more proliferative lesion and probably also membranous is still going to be there. So the proteinuria is probably from the membranous, but the creatinine could be from, she could have another proliferative lesion, class 3 or class 4. So we'll see what the biopsy shows. But I think she's going to have a proliferative lupus nephritis. Can't hear you.
What about a COVID-related lesion?
Yeah, I mean, COVID can make, either COVID-associated AKI or COVID-associated nephrotic syndrome, a collapsing FSGS. So those are possibilities. 3 months out seems a little, once I feel like if she was going to have this, she would have had it while she was infected. To have it 3 months later seems, I don't know. I'm not aware of that timeline being reported. So I think because of the 3 month gap, I'm going to say less likely that this is COVID related, at least directly related to COVID from an AKI or from a collapsing FSGS standpoint.
Yeah. So, I mean, do you think this all happened because basically COVID stopped her
because
from getting
she didn't get
immunosuppression?
Rituxan for 18 months, maybe.
Yeah.
I mean, that, her she's undertreated. Her lupus is undertreated is sort of my thinking.
You think that with this degree of AKI, that she'll have, like a really bad, like a much worse segmental or even crescentic lesion?
Yeah, I mean, she could have, with lupus, you can get TMA with lupus, you can get crescentic GN with lupus. Any of those things can bump your creatinine. She's also, I don't know what the timeline of the adding of the Prograf and the Bactrim was, but if it was that was added after the creatinine increase, they're probably unrelated. If they were just added when the proteinuria went up, maybe the creatinine is a little bit of those things. So I'm not really sure about the timeline.
Yeah, her creatinine bump and nephrosis predated the Prograf.
Yeah, and she could have ATN from just severe nephrotic syndrome, right?
Mm-hmm.
So those are all possibilities, which is, I think this is a perfect argument for repeat biopsy in these lupus patients, is because you just don't know, are we treating ATN or are we treating an actual, proliferative lesion in a setting of just a nephrotic membranous?
Or even, I suppose a podocytopathy and
right,
and AKI associated with that, because I mean, it sounds like it's pretty abrupt, and her albumin is what, 1.5 or something. That's pretty low for.
Right. The problem with podocytopathies is hard to diagnose that in somebody who has that biopsy, right? I mean, she already had diffuse food process effacement with membranous and a class 3. So, podocytopathy essentially being only diffuse food process effacement is probably going to be there. So how do you call that podocytopathy if she has membranous?
Well, maybe she doesn't have membranous.
Maybe she doesn't have membranous.
Exactly. Yeah,
she never had any extra renal manifestations of her lupus. I mean, this was all renal limited, more or less, that we're seeing.
Correct. That's correct. And I'm glad to hear that her nephrologist was under treating her. Thank you for pointing that out. It must be,
I'm
must
curious.
be clearly a quack. Thanks. a lot
Why,
for that,
why
Josh.
did you choose tacrolimus over cyclosporin? I'm just curious. Not that it's a big deal. I just,
No, you know what? I don't know. I think I just jumped right to that, thinking that I better control her, what I thought was going to be a membranous relapse as soon as possible while I was waiting for, and I just chose NEC&I, really, to tell you the truth.
yeah.
Steve, do you prefer cyclosporin? I mean,
I just have more experience with it. That's all.
The Mentor trial certainly randomized those two, you know, cyclosporin and Rituxan, and cyclosporin achieved remission as quickly as Rituxan did. So I can see why you'd want to go with cyclosporin. It seems like it's been better studied in membranous. So I'm not quite sure why I chose Prograf. I think I just put it on.
well, so where does that leave us right now?
So we got another biopsy. Let's spin
Yeah,
the wheel.
exactly.
So, we don't have to.
So here,
necessarily
we're right
spin the
here.
wheel.
We're right here with AKI and some
We can keep
proteinuria.
speculating.
Yeah. So either Casey reads it again, or
And
we spin the
Casey?
wheel
I
again.
can read it.
Yep.
Yeah, keep Casey on.
Give me a second here. I'm going to give you control.
He's not,
Where are
he's-
we?
Just,
Go ahead.
just that advance the slide. I'll read it.
Some
You
quack
advance.
nephrologist.
Go ahead. Click the screen. Yep. Okay, I'll advance the slide.
Okay, here's a low power trichrome. The blue stuff at the end here is the capsule. And I see some blue staining material, but it's not that much. I don't think there's much chronic disease here. I still see glomeruli that look abnormal, but I'm still going to say maybe 25% or so fibrosis. Again, I mean, these cores are a little misleading because this is medulla, and you know, I don't know how many cores we got, but David, I'm going to go with 25%.
Okay. Yeah. So, well, if there was real, you know, firm fibrosis, it looked like the capsule material, dark blue at the top.
Oh, that's
So-
fibrosis. Okay.
Yeah. I mean, that's collagen, you know, of the capsule. So yeah, it was just focal, you know, less than 10%. Yes. So we could go on to the next slide. Here we go.
All right, here's a high power H&E. So this area right at 12 o'clock, I see some keryrexis. I see a poly, and I see some cells. So here's a necrotizing lesion at 12 o'clock. There is definitely mesangial expansion. This looks actually, with the exception of this focal area, this actually looks better than the previous biopsies so far.
Yeah, Casey, I couldn't quite make a necrotizing lesion there. You know, when I look at the other stains, you know, there was no break in the GBM. I agree, there was a poly there and some nice red cells.
How about these
Um,
dots, these right here?
Nuclei.
Yeah, because then you could see, then when you look closely, like down over at 8 o'clock, I see a black dot similar to that, way down at the very, yeah, see, there's little black dots
Okay.
kind of, yeah, so.
Okay.
That'll be,
So maybe just
I could
mesangial.
see, I could see how you could say that looks like a
Yeah, I mean,
necrotizing
I mean, the
first blush.
architecture is disrupted, and I see these sort of like, you know,
Yeah.
dots. So I assume that was just keryrrectic debris from necrosis.
Casey, just click on the screen once. So you have, yeah, okay, perfect. I'll advance the slide.
Okay, so in that case, if this is not a proliferative lesion, then all I guess I would comment would be mesangial expansion and you know, mild hypercellularity in some areas, maybe six cells right here, but
Yep.
not much else.
Yep.
Next. Here is a PAS stain. Same thing. I mean, I don't see anything there's definitely no crescents, no significant abnormalities outside of just mesangial expansion.
Right.
Next. Here's an H&E. The arrow points to some TMA in these capillary loops.
Yeah, good, Casey. Yeah, intracapillary thrombi.
Thrombi, yeah.
Yeah.
David, you can't say good if you put the arrow there.
Yeah, I know, right? I didn't pick it
Well-
up, really. I just had to explain what the arrow was pointing to.
Yeah. Yeah,
Uh,
so
There's a
three,
big arrow
three,
too.
yeah, the 3 glomeruli out of 17 had these focal thrombi.
And look
Yeah,
how
when the
thick
when the
these
fellows read, they don't get
capillary
the
lo-
arrows.
and look how thick these capillary walls are. It's really thick. So we're probably going to see some abnormalities in the basement membrane, whether they're fresh deposits, we'll see. But this area here, so these are unlicensed red cells.
I said you did good because, yeah, they're not hyaline thrombi made of immunoglobulins. That'd be a brighter shade of pink, more eosinophilic. Or maybe somebody would say they're cryo deposits, but you said correctly they're interpreted as platelet fibrin thrombi.
Fibrin thrombi.
Yeah.
These are unlicensed red cells up here. So this area, is this sort of this doesn't look normal to me, right?
Yeah,
there's
maybe it's
mesangial
becoming a little
expansion.
ischemic, or
Okay.
yeah, and it's probably congested. There's not good perfusion in that segment because of the thrombi.
It's also very lobular. You see this,
Yeah.
you see this, you see this, and then you see this, right?
Yeah.
Okay. Thank you for the arrows again. So there's more TMA, more mesangial expansion, mild hypercellularity, no crescents. Up here is, I think, hanging off the edge. So I'm not going to call this break in the Bowman's capsule a break per se. Yeah, because there's no tissue around it. So same thing as before. There's nothing new here.
Yeah,
Casey,
so
I think you didn't know if a fellow was going to be reading it or an experienced
Yeah.
Nephropathologist like yourself reading it. So you're just
Yeah.
queuing it up so it'd be ready.
I appreciate that.
I think David should put a large arrow by a normal loop next time.
No kidding.
Just to mess with us.
Yeah. Here's a Jones stain or silver stain. Ignoring this part, everywhere else to look that I'm looking, I'm not seeing any holes in the peripheral capillary loops. Looking for spikes. I don't see spikes either.
Go up around 12 o'clock. There's one loop that
Here?
looks like that. Go down just right to the left, just to the left. Follow that around.
Here?
No, right to the right of that. That one loop.
Here?
No, you're
No,
at the cap-
the loop
right
here.
there, right there.
Here?
Yeah, if you follow that around, it just looks nubby as you go to the left side there.
Here.
No, that's okay.
Okay. Yeah. What are you seeing? A break?
No, I'm seeing what looks like it might be some spikes, but that's just, like you say, it's very subtle and there aren't many anywhere
Okay.
else which you'd expect to see. Yeah,
you
along.
are you
right
talking about
there.
this?
Yeah, exactly.
Okay. Yeah, I see what you're saying. It's, I guess elsewhere trying to look and see if
Yeah.
this is focal or not. Trying to see. I don't really see much else outside.
You're right.
That. Okay.
For all the proteinuria, nubby nephropathy, yeah.
All right. Here's some ATN right in the middle of the picture. So this is a tubule, proximal tubule. Epithelia has sloughed off. Here it's kind of thinned out with loss of brush border. So there's ATN in these 5 or 6 tubules right in the middle here as well. Looking to see if you've centered the mitotic figure. I don't see one.
Yeah, I
So-
didn't see any mitoses.
Okay.
Oh,
There you go. Yes,
Yeah.
you did right there.
Yeah.
And here too, right?
yeah.
All right. So 2 mitotic figures.
Yeah.
So good news, I guess. Maybe ATM will recover.
Yeah.
All right. Fluorescent IgG is positive. Pretty positive, actually. Granular pattern, both peripheral capillary loop. A little less so intense, but there's definitely mesangial staining as well. This right here, you see these mesangial granular deposit. So this is both mesangial and peripheral, which is interesting with the PLA2R being so positive. So I guess that's gonna be one of the things we have to discuss. So I hope PLA2R is next. Oh, or not. What's the tissue PLA2R?
Negative.
Negative. Okay.
Yeah.
Is this the second time this has happened?
So I mean,
We've
the
had-
only way that could be is a false positive serum, right?
We've had the other
Well,
way
I guess
around.
we'll talk about it. All
We've
right.
had the other way around. I don't think we've had it this way.
Oh, I thought we had a case.
We've had the tissue positive with serum negative, which can be seen because of the
Right.
whole zinc phenomenon. But the opposite, I don't think can happen.
I
Unless-
think Steve had a case years ago, if I
Well,
remember.
I don't know why I
And-
thought in the last few, doesn't matter.
Okay. All right. So EM going around the capillary loop. Again, diffuse foot process effacement, membranous. So I guess cannot call it podocytopathy. This is still part of the membranous nephropathy with diffuse foot process effacement. Here we have some deposits, some faint deposits here in the mesangium, but mainly peripheral capillary loop. Here, this loop as well. And I'm trying to think, I mean, if she's had membranous for all these years, she should have some intramembranous or some more changes in the basement membrane. These still look pretty large and pretty fresh. It's kind of
She
interesting.
keeps going into remission, you never know.
So she just kind of has these fresh deposits and then she gets really nephrotic. So this may be a fresh relapse as you've clinically picked up.
On that loop at 12 o'clock, you can see some spikes forming.
Yeah, right. This being one and this right here.
Yeah, and then in a loop next to that one.
Yeah, these are all
over there.
spikes, these
Yeah.
GBM coming around the deposits.
I mean, it is impressive that her basement membranes aren't more, modeled and things, but it may be that when she goes into remission, these things reabsorb and her basement membrane didn't get that damaged. I mean,
Here we go.
Who's
Here's
in-
some intramembranous ones. There we go. You asked there. It's a big intramembranous one because you can see GBM over it.
Yep.
Big subepithelial here.
it's really dark.
Here's
Are
a
those
mesangial
subendothelial?
interposition, right? Huh?
Are those subendothelial deposits or,
These are still subepithelial.
Yeah, those are.
but on the
yeah.
other side,
Here?
That's a cell.
it's a
So
cell?
the cell.
No,
Yeah,
on the right
organelles.
side, it's,
Yeah.
okay, that's interposition like he was
Thi-
saying.
This, you're
Yeah.
talking about this?
Yeah, it just looks so
Yeah, it
dark
should-
on my
Yeah,
screen.
this is a cell process. So this is mesangial interposition, right?
Yeah,
Okay.
yeah.
Okay.
What are those
Here's that poly we
deposits?
saw,
Yeah.
right?
Down at
That's
the
a poly,
bottom,
right?
are those mesangial deposits at the bottom?
Here,
No.
yeah.
To the left of that?
Yeah.
Keep going,
These?
keep going to the left.
Yeah.
Right there.
They don't look like
Yeah, we saw better ones on the last slide, in case you
Got it.
pointed out.
they have
Right.
the same texture, density as.
Well, I'm looking
as
at the really
normal
dark
gray.
stuff. That's why.
Okay.
Okay.
Those are massive.
Yeah, so here's the podocyte right here, huge deposit, but it's all subepithelial. And then diffuse foot process effacement. Here's the endothelium. Looking for TRIs in the endothelial cytoplasm. I don't really see it.
Right,
Yeah,
right
those-
at, I didn't see any.
Yeah, you've measured 333 nanometers on the GBM, so that's pretty normal.
Yep.
Okay. So at this point, this is histologically PLA2R, this tissue, PLA2R negative membranous nephropathy with mesangial deposits. So clinically, I still think this is lupus
And TMA
and TMA. Yeah.
and,
big-
and ATN.
Plus ATN, thank you.
Yeah. So why, what do you think the AKI is from of all those lesions?
ATN and TMA?
Yeah, I wouldn't wonder how much is even the ATN, because the TMA was, you said it was what, 2 out of some glomeruli, David?
It's a 3 out of 17.
Yeah, 3 out of 17. And
I don't know. Does that correlate like histologically how many lesions you see versus clinically what your creatinine is? I don't know if that matters. If you
I
see a
agree with you.
few,
I don't
TMA
think
is
that
TMA,
correlates.
right?
I agree. It doesn't correlate.
Yeah, I mean, years ago, there was an article, I'm trying to think of the name, the guy's name, the pathologist, about with focal lupus, focal segmental lupus, and those associated with thrombi. This was before antiphosphate antibodies were even able to be tested for, but those who were positive had a much worse prognosis than if you had focal segmental lupus nephritis without those thrombi. And I don't know that they ever quantitated, how many they had to have. I think just the presence was associated with a bad prognosis.
yeah, I suppose a kind of a model for that is atherosclerotic disease, where you can see really significant renal failure and rare rare evidence of that. And so maybe you're just seeing the tip of the iceberg and it's in other vessels, but there certainly was ATN. I'm sorry, I'm going to move this on a little bit. Casey, how would you treat this patient?
Get the Rituxan in, continue the MMF, and I don't know if I would necessarily give her 60 of prednisone. I could lower the prednisone, give Rituxan, and keep on MMF.
Bill, real quick.
And stop the attack because of the TMA.
Yep.
Yeah.
Really good point. Bill, from the standpoint of nomenclature with podocytopathy, you know, Casey made the point, well, I might not call it podocytopathy because of the presence of the subepithelial deposits, but haven't you guys kind of made the point that, you know, it may be its own lesion on its own, and that you could still call it that if you have that diffuse foot process effacement, even the setting?
I think our argument is that the podocytopathy really just refers to diffuse foot process effacement. So if it's isolated podocytopathy, then that's what we sort of used to call it, where it was just that alone. But membranous can have diffuse foot process effacement associated with a lot more proteinuria. So we would say that was membranous with podocytopathy. A segmental or even diffuse proliferative can have foot process effacement or not. And so if it's diffuse proliferative with diffuse foot process effacement, you'd call that a diffuse proliferative with podocytopathy. So we think the podocytopathy can be added on to any of the lesions, is my point.
Yeah, and I think your concept was that it may be an independent pathophysiology, and that's why sometimes you see it and sometimes you don't, and it kind of fits the very high degree of proteinuria here.
Yes.
Although it's a really bad membranous, let's face it. But
Well, I know you've got to finish up, but I thought, Bill, the other point you guys made was that it was independent of how diffuse or severe the deposits were. It was the foot process effacement that dictated the proteinuria.
That's exactly right.
Good point, Steve. Bill, why don't you tell us what you did?
Yeah, I mean, really a tough case. I didn't really know if the TMA was from the Prograf or not. The creatinine had bumped before, and so before I added on Prograf, so I clearly stopped it, but I wasn't sure what the cause was. So we also checked an antiphospholipid antibody panel because of that's association with membranous, and that was completely negative as well. So we were in a little bit of a bind to figure out the TMA, and I thought the TMA was a lot more responsible for the kidney failure than pure membranous. And certainly there might've been ATN there. So I agree with Casey. I don't really think that I wasn't thinking much of an inflammatory component to this. So we cut the steroids down pretty quickly. I didn't think that was necessary. And we were trying to ramp up giving her Rituxan also as fast as possible, which was pretty easy to do because she was in the hospital. But what I thought is because I saw the thrombi and we didn't even have the antiphospholipid antibody panel back yet, I went ahead and started plasmapheresis just in case this was something like a catastrophic antiphospholipid antibody syndrome or some other form of thrombosis that we didn't know. And so we gave her plasmapheresis, and Pravir, if you can maybe show the last slide, we gave her plasmapheresis, Rituxan, and steroids, and I got the Prograf off, and she actually stabilized quite well. Her creatinine had gotten up to 2.5. And before she left the hospital, it was back down to 1.9, and it's already getting better at 1.5. She still has about 6 grams, but that's already improved from 12 grams. And you could argue the pheresis may have done nothing. It might just be ATN that was getting better. The stopping the Prograf might have been enough. So I wasn't really sure, but I thought we better throw the kitchen sink at her because she was really going up with kidney failure, and I didn't see evidence of inflammation as the cause, like it wasn't a DPGN or a crescentic one. And so I thought we should at least try this, and it worked, but also other things might have worked.
I think it's a great case for what Casey brought out, is that, you know, sometimes lupus can change and sometimes you have to do a rebiopsy. You won't find a better situation than that. You could have thought, well, look at her DPGN, it's now worse. She needs Cytoxan. You get a second dose of Cytoxan, second round of Cytoxan or whatever. And you avoided that. And I think there's 2 really good points to be made here. And that is whether it's relevant or not, or true or not, the TMA that's associated with CNIs is a really good thought, you know, and I would never have thought of that at all as part of this picture, you know, and now it's a approved treatment for lupus nephritis. I don't know if the voclosporin's been associated with the TMA, if anybody knows, but, you know, this may not be the magic drug either, and may have that side effect. And the other one, as you brought up, is a really good point, and that is that antiphospholipid syndrome is independently associated with membranous glomerulonephritis. And Unfortunately, it's not the case here, but that's two really interesting teaching points.
And
to remain-
another
to
one
remain-
little point is before we even got to treatment, we also decided to send her biopsy for exostosin and thrombospondin as well, because we were really confused by the pathophysiology. This really high titer PLA2R in the blood, it is not in her kidney. And so we also checked her kidney for exostosin and thrombospondin, and they both came back negative. So
Yeah,
she
you
was
would've-
not exostosin and not thrombospondin either.
Yeah, and we could have put a little poll out on that because I think I would have thought this was going to be exostosin positive. I still have no explanation for the PLA2R. Now we know that lupus is an autoimmune disease and PLA2R is more common in patients with lupus as yet another autoantibody, but I don't know that this has been described where they get the antibody and it doesn't deposit in the kidney, and it's who knows what to make of that. I don't think we're going to know. And how
There
we're
was
gonna be-
there was a series that looked at people with PLA2R serum versus tissue, and they had, I think, 3 or 4 cases where it was positive in the blood because it was obviously they used ELISA, and then the antigen, it was the immunofluorescent in the kidney, and the kidney didn't have it, and they basically said that's just false positive. There's no explanation for how you could have a negative tissue staining and a positive antibody in the serum. So I don't know. I wish Diagnostic was here to kind of tell us about that, but that's the best I can tell, is that it starts, obviously it starts from the blood, it deposits in the kidney, but then the kidney kind of acts as a sink, so it could actually be negative in the blood, and then it becomes positive, and then when the antibody goes away, it's still positive in the glomerulus, and then proteinuria starts. So they have this stages, like I think 5 stages of PLA2R positive membranous.
And there are other, there are other antigens and antibodies associated, but these are the only two that we're able to that we have access to be stained for at this time. But I don't know, we're going to be able to sort this out. I think, as time goes on, these will become clearer as well. Bill, good job on the treatment, because like you said, who knows, but to pull a trigger on Plex, it's an easy thing to do and it's not an easy thing to do. And who's to say it helped her or didn't help her, but I think it was great, and the outcome is great. And the Rituxan, it sounds like she's going to need chronic Rituxan therapy. This woman really wants to relapse. She's got bad lupus, and is that what you plan on continuing as her chronic maintenance therapy?
Right, and I was already doing that, and the reason we held it was because she got COVID. But I was planning on doing it annually, and she'd been doing pretty well with that. But I'm probably going to have to step this up to 6 months for a while, and then we'll maybe cheat it out to annually again if we can. But yeah, she has basically a Rituxan deficiency.
And are you going to give her? Would you tell her to get a booster?
Yeah, I think so. She did well with her immunization.
I just my point being that we've seen a lot of relapses associated with booster, and then of course you have to time it with Rituxan. Maybe at the end of her 6-month period, give it, because if you give it in the middle of it, she probably won't form antibodies. I mean, it'd be interesting to see if she even has any antibodies.
Right.
She probably does because of the timing of everything, but she may not. It may be worth checking her antibodies and kind of working that out, because she's going to get Rituxan for a long time, and I don't think COVID's going to go away in the next 2 weeks. So it's something to think about. Very specifically how to time all that and what to do for her, and that might require antibodies and holding Rituxan a little bit, giving her the vaccine, and then restarting it, taking a chance that she might relapse, and realizing that the vaccine itself is more likely to make her relapse. It's a really tough situation we're in with these autoimmune diseases and COVID. You don't want them overly immunocompromised so they get COVID, but then also you give them the vaccine and you might have a problem with it, but you don't want to give the vaccine when they're getting Rituxan if they don't respond. And also you don't want to plex them and remove the Rituxan. So it's, you got to really think twice about all these things. That's a great case. Thanks, Bill. Thanks, everybody. I'm going to wrap this up. The activity code again is 484222. Check your email. We'll probably be back next week. Until then, everybody stay safe.